Okay, why don't we get started, Rob? And if Chantal pops in, give me a wave so that I can see her come on, and we'll just get started and hopefully she joins. Welcome, everyone. I see a few more people signing on, so we're just getting started now. Good morning. Welcome to the session on integrating child and youth mental health and substance use care into community PCN planning. I am very grateful to be dialing in from the unceded traditional lands of the Musqueam, Squamish, and Tsleil-Waututh Nations. My name is Krista Walbank, and I am a Senior Project Coordinator with Doctors of BC. I have the pleasure of supporting the Child and Youth Mental Health and Substance Use Community of Practice, which is a provincial initiative supported by Shared Care. I'm sure you're all very familiar with the Shared Care Committee. I work closely with our two physician presenters today who are leaders in the community of practice and very passionate about this subject. Dr. Rob Lehman, who give us a wave, Rob, is online, and Dr. Chantal Guillemette, who unfortunately is not on yet, but hopefully will join any second. I'd like to thank you for joining us today and for sharing this virtual space to talk about the importance of addressing child and youth mental health in our communities and how we can do this through PCN planning and implementation. So I would like to pass the mic over to Rob now to more fulsomely introduce himself and begin the presentation. I will be sharing my screen, so just let me know when you want to hit the next slides, Rob, and we can skip over Chantal's portions if she's not able to join us today.
Okay, thank you all for joining us. I found the morning session really stimulating to learn more and more about what phase other communities are at in their PCN development. And I think that's a really good ground for us getting information for our own communities. My particular interest at this stage of my career is in child and youth mental health substance use. I guess I realized when I look back over my career, as we learn more and more about adverse childhood experiences, it has, actually, before I go on any further, I want to also acknowledge that I'm coming to you from the traditional unceded territory of the Shishal and Squamish nations. And I apologize for not saying that in the beginning. And also a little bit more about me. I've been a family practitioner on the Sunshine Coast for 40 years. I retired from my practice 2 years ago. And as I mentioned in the panel this morning, sort of wanted to dedicate this stage of my career to kind of giving back and particularly in an area that I feel is really vital. So I'm on this provincial child and youth mental health substance use community of practice that has approximately 270 members across the province, I think, Krista. Family physicians, child psychiatrists, pediatricians, all working to try to advance the advocacy for more seamless child and youth mental health and substance use care all across the province. So in chairing the Community of Practice PCN working group, this is that opportunity to try to advocate in a larger forum. And again, thank you for being here, for how the importance of really including child and youth mental health substance use as a significant part of what we're doing in our PCN planning in our communities. So that's really where this stems from. And going back to what I was saying previously, when I see the increasing evidence of the impact of childhood adversity on all of us, and certainly on what we see in our office practices with illnesses, not only mental illnesses, depression, anxiety, but also the physical illness that can result from a lifelong exposure, even early in life, to adversity, the ongoing effects that can have down the road. It really struck me how critical it is that we start addressing more effectively that childhood adversity, whether we try to prevent it from happening in the first place, or if it has happened, how we can mitigate the downstream damaging effects. So next slide, Kristen. So really what we're starting to look at is why is child youth mental health substance use care important to our PCN planning in our community. Next one, thank you. So firstly, I'll just go back and talk a little bit more about ACEs. Now, that's adverse childhood experiences. I'm going to assume you all know a little bit about ACEs, but I'm not going to assume that you know all about it. So I'm just going to give a little bit of a Cole's notes about ACEs. And this is what really impacted me in this work, is the sort of seminal study was in San Diego many years ago now, when they looked at adversity in childhood, and they looked at 10 areas, category areas of abuse, neglect, marital conflict, mental illness in the family, incarceration, parental separation, and violence in the home. And in this study, they found that 65% of the respondents, there were 35,000 people in San Diego, 65% of the responders had at least one adverse childhood experience checked off in that list of 10 that they had a list of. So really, I'm saying that just to make it clear that this is not a small issue, and this is something that's been relatively unrecognized in our culture, and certainly unrecognized in my practice. And still, I started to become more and more aware of it, and it really started to make more sense as to why I was seeing some of the illness outcomes that I'd been seeing for many, many years. When you combine that adversity in a home environment with environmental adversity, such as poverty, racism, discrimination, constant moves in your household, violence around you, and the lack of social opportunity. You know, it's not a doom and gloom, but I just really want to point out that all those social determinants of health have huge impact on the health of our patients. And I guess really what I'm coming from is just acknowledging that this is a common issue for our patients, and the downstream effects, both mentally and physically, are really very significant. The next slide, Krista. So just a bit of a summary slide. Again, what we see is through that adversity, we see people responding in varying ways, developing coping mechanisms for trying to manage experiences that are often kept secret, or there's a sense of shame or unwillingness to divulge, and it affects behaviors. And we all know that certainly it forms as seeds for addiction, use of alcohol and drugs for trying to find ways of escaping or managing, smoking, a decrease in physical activity, often related to self-concept, and what's the worth. And that can have an effect on physical and mental health outcomes, such as with the lack of activity, dietary selections, obesity, suicidal attempts, marked increase in suicidal attempts, 4 to 10 times greater, depending on the level of adversity. Frequent sexual partners that can lead to an increased risk of sexually transmitted disease. We also are recognizing that effect of chronic stress on people can create a sort of inflammatory cascade as that stress lingers, and that can lead to all of those. What we now know are those inflammatory results can happen with cardiovascular disease, with an increased risk of heart disease, strokes, chronic lung disease even unrelated to an increase in smoking tendency and with people that have had higher adversity. And then the mental health outcomes with depression and anxiety. So next one, Chris. So what, as I say, I've worked on the Sunshine Coast for 40 years, and I've been retired from my practice. for 2 years. But in looking back, I am now looking forward with seeing this opportunity with primary care network development. My experience, and I think I mentioned this at the panel as well, was having kind of immersed myself in a team-based care environment in my training in Ontario in my family practice residency. It was a team-based practice. And with coming back home to BC, really recognized that even though I was in a group practice, it was basically me doing my job and sharing overhead and doing call schedules with my fellow physicians in our rural practice. And it was kind of that siloed care and very little interaction with particularly child serving agencies in our community, notably child and youth mental health with the Ministry of Family and Child Development. So what I saw as an opportunity here was breaking out of that siloed care that we had been trying to provide for many, many years through the Child and Youth Mental Health Provincial Collaborative that I'm not sure how many of you were involved in that, but it was a collaborative over 3 years, Chris. I think it ended in December of 2017. But out of that collaborative, a lot of communities formed local action teams. And those local action teams for us involved our family physicians, our school district, our Ministry of Child and Family Development, our Shishel First Nation, RCMP, ambulance service, all coming together to share information about what we were doing in our individual areas around child and youth mental health care. And that local action team has continued to meet on the Sunshine Coast, even though the funding for it ended years ago. But I think it was the recognition of how valuable that was. Through that local action team, we spearheaded a doctor in the high school program that we do in collaboration with child and youth mental health and substance use, taking that clinic 2 afternoons per month to our high schools so that we would be much more accessible and we could share that care when necessary with the counselor from child and youth mental health, whether it's a physical issue that we would deal with as the family doctor or a mental health issue that they could talk to us first and then see the counselor through child and youth mental health. So that was one success story of that collaboration with child and youth mental health. Through our local action team, we also developed what we call marijuana panels. So for the last 5 years, there's been a small group of about 5 of us from those different members of the local action team that have gone to each of our 10 elementary schools in the grade 7 year, because we found the greatest risk for children experimenting with drugs and alcohol happened between grade 7 and grade 8. So we wanted to offer them information about marijuana, and that expanded to other drugs and alcohol and peer pressure and all those other issues that come up, certainly at that age, in a dialogue, not in a top-down, you should do this approach, but just in a dialogue with youth in the elementary schools. And that has actually demonstrated through a study we did after the first year of doing it, that there was a decrease in a subsequent survey of children in their first experimentation or decision to try alcohol or marijuana, particularly in this case. So it did demonstrate a positive effect. So those marijuana panels are continuing, and that stemmed from that collaboration with those other groups in our local action team. Now with the advent of primary care network development, we've also instituted a child and youth mental health substance use working group for our Sunshine Coast primary care network. And I've been meeting with family physicians, members of those other agencies in the community to say, what do we need to help us with the networking for more seamless child and youth mental health substance use care in our community. And I guess this is what we're advocating for, is that inclusion when you recognize the downstream benefit of preventing or mitigating some of the factors that can lead to mental health and substance use problems with our children is so beneficial as a critical factor in what we do in our networks and our communities. We, through the local action team, we have been having meetings from a smaller group from our Division of Family Practice, the school district, Shishel First Nation, Ministry of Child and Family Development, and our community services group, who do a lot of outreach in our community, looking at having an integrated care conference in our community, inviting members from each of those groups as an information sharing opportunity, but also to try to see if there was a way we could turn our information sharing into more of a clinical entity, more of a team-based environment for that seamless child and youth mental health care that we're talking about, which is one of the hallmarks of PCN, as you know, is the development of team-based care, as well as trying to increase attachment numbers for people to a primary care provider. And that's kind of where I engaged with the provincial child and youth mental health substance use community of practice that Chris was mentioning at the beginning of this discussion. And that is that opportunity to advocate with government for them to recognize that all of those child serving ministries need to work together at that level to start collaborating and coordinating this more seamless care for young people. It sounds like a tall order, but we've actually achieved significant success, I think, in advocating for that interministerial connection, collaboration at a macro level, as well as trying to do that individual work in our own communities at the micro level. Next slide. Now, I don't know, has Chantal been able to join us? Do you know, Chris? Oh, goodness. Chantelle, just to mention, she has recently joined our, she's a family physician in Kaslo. She's recently joined our PCN working group through the community of practice. And I was really hoping she'd be here because her story is really quite fascinating. There's a group of 4 physicians that attend primary care in Kaslo. And they started recognizing there was a real increase in suicidal thinking in their young people in their community. And she quickly realized that she could not help or manage this problem without soliciting the help from other community agencies. So they met in their high school with the community services, the school counselors, and developed a team model for how they could try to respond to this suicidal risk in the community, because one child was actively suicidal, which was having a downstream effect on the peer group around that young person. And through that, they developed a doc in the high school program where Chantelle attends, and again, in concert with Allied Health, taking that care to the high school, where she's actually had group visits for young people as their trust level increases there, which has had a significant benefit for that community. She's also reached out to her division, which is West Kootenays, I believe, to have this inclusion in their PCN development in West Kootenays, the effort she's made with the team-based care model in Kaslo. So really her story is compelling because it's meeting a need in the community, recognizing the benefit and the merit of a team-based approach, and then trying to get it to a broader picture within her PCN planning for her larger community in the West Kootenays. So it's a beautiful story. She tells it way better than I can. But again, it's just a really lovely description of the reality of how we can do a more effective job when we work in teams. And you heard this at the panel this morning, is because we tend to want to try to do everything ourselves. And most of that we actually do, and we do it really well. But it's really recognizing that we don't have to do it all ourselves. There are other people out there that can really help us in a really significant way with those social determinants particularly. So you're hearing that most communities are looking at a social worker as one of their first needs, community counselors for easy access in a team-based approach. So many PCN networks in communities around the province are trying to employ people in the mental health field, and that speaks for itself. So what we're really trying to advocate for is getting that care really well entrenched in children and young people and their families, so we can help to prevent some of that downstream damage that does happen. So these are the opportunities that we have is through our community PCN planning, is to really increase that awareness of mental health and substance use problems in each of our communities. Developing a team for that counseling and social work and addictions treatment, that's going to really vary hugely around the province as far as how much of that you already have available. Like in a community like ours, there's not a lot of that available. And in a lot of rural communities, there's going to be a minimal amount of that available. But if we advocate for that, if we look at how can we access that, whether it's in person or whether it's virtual, what mechanisms can we develop in our primary care network planning to provide that kind of service, that educational support, early recognition, and then the actual treatment parts when the problems do develop. Now, I've mentioned this a few times, mitigating the impact of ACEs and trauma. Other people like public health nurses or community services, or the school system, they're in places where they can actually recognize that adversity often way, way earlier than I will see it in my office. So if we develop a system where we start recognizing where the risk is and we start picking up problems earlier on, then again, we can help to prevent or mitigate that adversity and its outcomes way earlier in the system before it ends up with somebody with an overdose in your emergency room or with a heart attack way earlier than they should have had it because of a life of chronic stress. And that's what I'm saying about protecting against future mental health and substance use problems by that early recognition. And again, we're well aware of this opiate poisoning epidemic we have in the province, which has been a disaster for several years now. And how can we address that in our own communities? How can we advocate that provincially to get a handle on it? So what can we do? What can you do in your community PCN teams? Really, this is what we've been speaking to, is including child and youth mental health substance use care as a priority. And I hope you're seeing, and I'm really looking forward to questions about this, but I hope you're seeing just from what we've been saying so far, the merits of including that in your PCN. And the network building, again, we've alluded to, we don't have to do it all ourselves. And we have varying relations with child and youth mental health and MCFD in our communities. I'm well aware of that. We've been trying to bridge that relationship in our own community for many, many years and have been successful in many, many ways in doing that. I know that's not the case in other communities, but this is a plea to engage them in your community. And other community child, youth, and family serving agencies like our community services I was mentioning in our community our Shishel Nation, your First Nations, Indigenous people in your community, engaging them as you're developing your networks, because they're going to have, and engaging your community generally, as Karen Koski was saying on the panel, how that tremendous community engagement has worked for the benefit of the Whistler district. Getting that community engagement, getting that enthusiasm and that power that comes in the community numbers to help you in developing your PCN. And really, I guess, getting this message out regarding that prevalence of childhood trauma, remembering at least 65% of us have at least one adverse childhood experience in our lives. And how the other interesting thing is, when you're seeing these presentations in your office, you're often going to get triggered by one of your patients that for some reason doesn't trust you or never follows through on what you've recommended for them, and just doesn't seem to be making those right decisions. I know you're all familiar with that person, but as you start to recognize where that kind of behavior stems from, it really allows us to realize how vital it is that we take that trauma-aware approach to, well, everybody in our lives, but certainly to our patients, and what a difference that can make when you start recognizing and understanding the effects of trauma. And it allows us to be more compassionate in how we respond to that, rather than judging. We start to ask that question, what happened to you, instead of what's wrong with you. And if you're interested, join the other 270 members of our provincial child and youth mental health substance use community of practice around the province. It's not a huge commitment, but if you're interested, we have conferences now on Zoom, but there's still really fascinating topics in those conferences. And again, that's building that energy of the group, which is so much more effective than trying to do it ourselves, which is really what PCN is all about to begin with. So that was, I'm sorry that Chantelle wasn't here. I'm not sure what happened to her, but we'll open it to questions now. Thank you.
Thank you so much, Rob. That was a great presentation. So yes, we'd like to open the floor for questions and discussion. Rhonda, could you let me know how much time we have actually?
Yeah, and we have till 12:15. We have 1 hour.
Oh, we have a whole hour. Okay, great. So we'd love to open the floor. We want to hear from you. We want to hear about your experiences in your community, takeaways from Rob's presentation. I have some prompting questions, but I'd just like to open the floor for anyone who's keen to start us off.
I have a question.
Yes, go ahead.
If you could talk a bit about how you actually got child and youth mental health to engage with you.
It was through the local action team, because we were already meeting together in our local action team that stemmed from the Provincial Child and Youth Mental Health Collaborative that I was referring to. Just making those connections, because they sent their director for child and youth mental health and their general manager for MCFD locally. Both of them came to our local action team meetings, which was a first step. It was so great to have them there. So it was through that connection and that information sharing that we formed the base of the connection. And out of that, that's where their contribution to the marijuana panels, their contribution to the doc and school came. But I realized that was kind of me doing that with them. So what we did, we also planned an evening event when we actually could meet in person, where it was a dinner hosted by the division, where we invited all of our family physicians, our psychiatrists on the Sunshine Coast, and all of the child and youth mental health MCFD staff to an evening meeting We assigned seating so that people couldn't sit in their familiar groups. We had family docs, psychiatrists, and MCFD child and youth distributed in the tables. So you had to sit with somebody from the other side. And we developed 3 case examples of presentations, which really was a kind of a bonding experience, because we walked through those case presentations and they were all different, very different levels of things that we would handle ourselves as family doctors, but things where, you know, you realize I can't do this by myself. And walking through those cases, we started to recognize where child and youth mental health particularly could help us out. And they started to recognize that we're out there trying to do all this, but we just can't do the job we need to do. So it was just like, and once we got more familiar with each other, the judgments kind of stopped. Like, you know, when you don't know somebody, you just think they're doing their own thing and they don't really give a damn about you. All of that judgment sort of went away. And the other thing, we learned a lot more about child protection. I always saw them as the boogeyman that would just take my little kids away, you know, but hearing their point of view was so refreshing and so informative to the family docs to hear about how child protection, for want of a better term, fits into this whole scheme of helping children. So it was really quite a beneficial experience of having that meeting because the familiarity and the relationship building was huge just from one meeting. And then we've had the continuing interaction through the local action team. We also applied for a Foundry for our community, and our whole local action team was integral in trying to develop our expression of interest for a Foundry. We weren't successful, but again, it was another experience. And the failure to get a Foundry is what led to this, having the discussions about an integrated care team, which is where we're going to develop this conference for in the new year.
Great, thank you.
Okay.
Does that answer your question?
Yeah, it does. And that idea of walking through the case study is really valuable. So thank you for that.
Great. So essentially, dinners are very important. You should all eat together as a first step. I'm wondering, Rob, if you have any comments on what if a community didn't have a local action team to be that sort of initial connector? What advice would you give?
Okay, so maybe I'll just answer that before Janet, we take your hands up. Is that okay? Okay. I guess it takes that added step. There will be a manager or a director for child and youth mental health, or MCFD or MCFD in your community. And and we've developed kind of a one-pager through the community of practice about advocating for child and youth mental health advocacy in PCNs. And one of the lines in there is invite your child and youth mental health MCFD people to your PCN planning. So really it's trying to reach out and establish a bridge with the MCFD people in your community, because likely you don't have a lot of interaction with them or even know who they are for that matter. And you're not alone if that's the case, but it really is just getting a little bit of background, because in this realm of child and youth mental health and substance use, they can be such an advocate, and PCN is a Ministry of Health initiative. And it just doesn't make sense to me why in developing PCNs to the Ministry of Health, they didn't engage MCFD to say, look, you guys need to be part of this as we're advocating for primary care networks around the province. So it just means doing that added legwork of trying to engage the local people in MCFD with your effort. Does that help?
I think so. And Rob, is it possible we can share a link to that one pager? I think
Absolutely.
So.
Yeah, we'd love to distribute. We're just finalizing it, but even that drafty stage would be great, Chris, if you would.
Yeah, no problem.
Thank
I can
you.
send that out. Janet, over to you.
Thank you, and thank you, Rob, for sharing that that presentation and your experiences. It sounds very similar to the work that happened in the Comox Valley. We were part of that Child and Youth Collaborative, and once the official funding for that ended, we sort of had a period where it went quiet, and we tried to keep it alive, and then it just faded away for a while, and now it's come back, and it's really a community. The division supports it administratively, but it's really a community group that's pulling it together. They came up with the name of Children and Youth Matter, Comox Valley, and they were instrumental in our Foundry application, which we were successful for. So we're just awaiting the implementation of a Foundry. We submitted our service plan before Foundry was on the landscape, really, and so we're excited that the Ministry of Health has recognized that we didn't understand the relationship to Foundry when we were starting PCN, and they've allowed us to add some resources, a physician time to support the Foundry, which is great. You were kind of alluding to my question, Rob, or my comment that we were also engaged with the Ministry of Mental Health and Addictions around the Pathways to Hope work and integrated teams in the schools. And I think, I'm not sure what happened to that initiative. The division was initially invited to participate, and then through COVID, I just remembered that it's kind of disappeared, and I need to put it on my action list. But I'm wondering if you've had any engagement with the Ministry of Mental Health and Addictions directly through this process, not at the local level, but at the sort of leadership level.
I have communicated with Nick Grant, who's an assistant deputy minister through MMHA, about those IC teams, those school district-based mental health community teams. There were 3 that were originally allocated, and honestly, I don't know what's happened with that, because those 3 communities still really have not really successfully started that process for developing those school-based community mental health care teams. Nick Grant said there are 15 more of those that are going to be planned around the province, but he didn't give me a timeline as to when that might be coming forth. But again, that's one more of those collaborative areas. Unfortunately, when I look at the IC team composition, family doctors are not included in the ground team. We're add-ons as a possible supplement when we're needed, which we were also advocating for changing that, because if you don't start with recognizing that we manage at least 75% of the mental health care needs for the population of our province, and you exclude us from something like this, and it's such a dumb ass thing to do if you don't really look at the people that are integral to the care being provided in the first place. So we need to advocate for that in those IC teams as well. Okay.
Thank you, Janet. Christy?
So my question, to a little bit of a backstory, where we are in the northeast of BC, we're not even a division yet. So we're in the midst of even creating a South Peace division before we can even start a PCN. But I was an early draw PCN nurse practitioner. And so, you know, in the midst of trying to get this all organized. So to kind of rewind right back to the baby stages of creating this working group, what did you guys do for community involvement or engagement? Did you guys send out surveys to, say, the high school and see what gaps that they recognized that they needed in care? Or what did you guys do to find those gaps, specifically right from the mouths of those children?
We went to, I was the one that spearheaded the in our high school in Gibson. So we, through Child and Youth Mental Health, the school counselor and the school vice principal, we asked them to gather a group of students that they felt could represent the children in the school. to come and meet with us. And it was really that dialogue about how could this work for you? What gap could be filled? How can we promote that access for the students in the school? So it did start with that grassroots inquiry. And then a small group of us actually went around the introduction to each of the classes in the high school and did our little pitch and answered questions in the classrooms as well. So that was really that need to address the people that were going to be served. So does that help?
Yes, thank you.
Okay. Which takes me to in the panel this morning, what we talked about, and Karen really struck me when she was talking about that incredible community engagement they had before PCN ever developed in Whistler. It just made me realize, as we're just developing our advisory tables for PCN, how important that community engagement is, and particularly when you're having any stress with your health authority or the ministry itself, to have your community have your back to support you on what you're trying to achieve through your PCN service planning and implementation. I can just picture that's going to be a huge asset once we get that up and running in our community.
Thank you.
Okay.
Thanks, Christy. Yeah, Tracy.
Thanks. Hi, Rob. Thanks for your participation this morning. I'll just put a little plug in. Dr. Diane Dunsmore-Farley, who's a community resident on Gabriola, is giving a talk this afternoon on community engagement, and she's in my community of Gabriola, and it's been an amazing journey to work together to build a community health center and to then go on deeper and deeper into community engagement. So anyone who's interested in community, she will help us with that this afternoon too. Rob, our community, Little Gulf Island, close to Nanaimo, but not close enough for it to actually be helpful in many ways. 40% child poverty in a community that otherwise is fairly wealthy. So there's a huge income gap. Anyone who's here with a young family tends to be in the poverty line. And then there's a bunch of retirees who are disconnected from anything to do with our school or the needs of our children in our community. And so we've done a ton of stuff to try to engage and to try to get work done. But I'm curious if you know of any models, or if your model has, the only way I can see that we could do it would be to do like a wraparound care that involves the families and the children, and not just the children and not just the families. And we ran into a ton of barriers with trying to figure out how to do that, because our social worker and mental health nurse were told initially that they couldn't work with kids because that was outside through their health authority roles, that they weren't children workers, they were adult mental health workers. So we kind of tried to work with the parents, but then we can't. So there's barriers and silos of care, as you mentioned. Do you know of any models where, there's a community support worker, for instance, rather than a social worker or a mental health who is involved with families, like helping the kids get to school, helping the parent, like there's so many challenges within the family structure. And so we try to deal with these kids individually with their depression and anxiety, but we know that what's happening is chaos at home, and we're not necessarily invited in to help solve that problem. I don't know if you can comment on that piece that feels the missing piece in our community.
Well, firstly, it's disappointing, isn't it, that when you see a need as a physician, you just want to fill it. When somebody is sheltering themselves because of their role definition and not fulfilling that need in your community, I just could imagine that's incredibly frustrating. We know that we can't, most of the time, help a child if we're not also helping the family and the caregivers. I guess that's where I'm coming from as far as MCFD and child and youth mental health, because that is their mandate, is to help us manage those children and their families and support for all of those social determinants issues, which is really what I was talking about with the ACEs at the beginning. Unless we really help address those social determinants and those risk factors for adversity early on, you're just going to see more and more of these downstream effects. So I guess Do you have MCFD, child and youth mental health, on Gabriola, or do they come across from Nanaimo, or how does that work?
They come across from Nanaimo. Different workers for different families. Like there's not even a consistent one person that would be the same person that would, you know, be connected to our community. Angela A. Pounds, who's here, who asked you a question earlier, she's a social worker in my community. We work together. Certainly not our mental health workers that didn't want to provide that support. It was more the guidance from above. We've wiggled around that a fair bit. We have a great team on the ground. Yeah, so it's the piece of like confidentiality. Like, so if a kid's working with me and then I become aware of a challenge within the family, how do I'm just weaving through those pieces. How do we, and families who want to talk to us about what their kids are telling us and we're not able to share information with the family about what the kids have said directly. So I'm just how you walk that line between caring for the individual and also caring for the needs. Because oftentimes we see that it's the anxiety of the parents around substance use specifically, I can say, but then the kids are like, no, you're not allowed to tell my mom what I'm telling you or what's going on with me. But then the parents are calling us and saying, what's happening? Why aren't you helping my kid? I'm just curious how you navigate that piece.
Well, there's two answers. One is that the confidence of a young person you're speaking to wanting to keep information separate from their parents. And in the end, if they're old enough to be making decisions, then you have to respect that privacy and confidentiality. The only time you broach that, as you know, is if there's an imminent risk to themselves or others. But apart from that, we do have to respect that confidentiality. There's no easy answer to that. And it's often how you approach the young person with, what do you think of your parents knowing about this? Do you think they'd be worried about you with what you've just told me? And trying to approach it in that way that you're not saying you have to do this, but getting them to reflect on, are there reasons for not engaging your parents? Is there a fear that you have of engaging them? Whatever, just trying to take that approach. The second part is what I've found with confidentiality statements with the Ministry, for example, of Children and Family Development, is often as it's a smokescreen for not engaging. So one of the things we did early on at our local action team was we grappled with this issue, and we had an outside consultant come in and talk to us about privacy and confidentiality. And through that interaction, we realized we don't need to be doing this. We recognize that we could have, on a need to know basis, we could have conversations with each other, not hiding behind confidentiality, but recognizing this was for the general benefit of this youth and their family. So we made an agreement that is the basis of our discussions, and maybe it wouldn't hold up, but that's what we decided locally, that's what we would do. That's one of the benefits of knowing each other, though, and having that relationship, is the trust is there to be able to have a conversation like that. Does that help, or does that just get things more confused?
No, it does, because I think that's where, when I think about having a local table or an action group that kind of as a community helps us deal with these crises, it's how we talk about the family, especially, and this is the same for your community as all of us really, in our small community. So if we're involving the school, and we're involving our local social service agency, and we're involving the ministry, and we're involving the physicians, the social worker, to talk about a family, how we do that in a way that's respectful of them and centering them and helping them. But it's also aware that you're putting that person in a spotlight that maybe they won't be comfortable being in. It's a very fine line to walk, but I look at like seniors' mental health in the way that if a dementing senior needs support, there's this whole team-based care that will come in and do that. And I would like to see a similar thing for children and youth in community, where there's caseworkers and support people and social, like there's a whole team for our elders and there's zero team for our children. And it doesn't make sense to me, but it's crossing that line of like, who gets to be involved, who needs to know, how we negotiate that with the family. It's just, yeah, it seems complex, but it feels really vital.
You know the concept of wraparound care, I'm sure. Yeah, and what you're describing is that dream of the wraparound care where it's a supportive team selected by the young person and their family. It could be the local clergy member, you know, a good friend, an aunt or an uncle. And that is, who is your support team? What are the strengths that you have? And how can we support you based on what you're saying is your need and what's going on for you? I've always had this fantasy of wraparound care, and Foundry actually, the basis for Foundry is exactly that, of trying to create that environment that's not medical, but it's that welcoming environment where you can try to provide that kind of wraparound care.
Thanks, Tracy. Thanks, Rob. Helen, over to you.
Thank you. Thanks, Rob. Excellent presentation. I actually have a few questions, but my first one is around the patient medical record and what kind of tool you're using to share information. We have one project, it's a separate project, but looking to do detox support in the community. And it's really challenging. And the big challenge is how to communicate and share information across different groups with different EMRs. So that's my first question. And if I have time for another one, that'd be great.
And I'll tell you what our experience is, but I know that all of these other people that are on this at this meeting will have their own experiences. So I'm quickly wanted to devolve into more of this being a larger group conversation as well. But it is frustrating. On the Sunshine Coast, all of our 5 clinics have the same EMR, MedAccess, yet they don't communicate with each other. And so we can't even communicate amongst our clinics with our EMRs. We have not figured out, and we're at this early service planning stage. We've got an information technology working group, in fact, that's trying to work with TELUS to help us figure out how we can integrate our EMRs. That doesn't even include other people in allied health professions at this point. We're going to try to incorporate our new allied health professionals into our clinic EMRs, but wouldn't it be so great if there could be cross connectivity of those EMRs so that we could share that information? I don't know if other people have other experiences in their communities. It's certainly not something we've answered.
There was an app that was being proposed, and unfortunately, I don't know the name of the app, but it was, you know, and everyone would have an iPhone. And supposedly it met the privacy and security restrictions or legalities. But it's complicated. And, you know, you're charting in something separate then from, there's need to duplicate process. And yeah, anyhow, that's one challenge. Signal, it is Signal. Thank you. Yeah, so the issue we actually had a social worker who did not have access to an iPhone, and they were instrumental in this whole process. And I should also add, didn't have access and does not want or will not use that kind of technology. So that was a whole separate challenge and limitation, which can be really frustrating, but these are the challenges that you face on the ground. My next question is around Foundry. Because we haven't started PCN planning in most of our chapters, and yet some of our communities have Foundries, and so they're approaching us and we're working together with them. But it's a little bit backwards because we haven't had that time to really reflect on what the needs are and what it might look like, and so some of the questions are around physician resourcing and support, and what does that look like? And I was just wondering if you might have sort of a few recommendations, or anyone else on the call who's involved with Foundry, some suggestions for us as we are engaging around Foundry before we've embarked on our PCN planning.
So I will throw that out to the audience, because as you heard, we were not successful in our own Foundry application, but anybody that's has a Foundry in their community, could they comment on that?
If not, Rob, I'd be curious sort of what would be sort of important components. Like, you were applying for Foundry, and so I'm curious what would be sort of key components that we should consider in engaging around what physician involvement and participation might look like.
Well, our division of family practice was one of the three kind of base groups that were applying for Foundry. It was spearheaded by Community Services, because you need a nonprofit community organization to spearhead it. But our Shishel First Nation and our division of family practice were the other two members that were sponsoring it. So that was where the local action team came in again, is because we were kind of working on all of that application material. But it's engaging the youth in the community for getting their input. So various steps in that process. Brainstorming session we have a ribbon community over 100 kilometers of coastline. So how do you have a Foundry when you've got this distributed population? So we had to kind of conceptualize what that would look like. So there's all sorts of factors that we had to work with for what that would look like in our community. As far as, that PCNs are now going to be responsible for Foundry as being part of their planning. So I'm not sure how that's all going to work. Certainly for us on the Sunshine Coast, we'd still love to have a Foundry, but I understand the next release is not going to be until 2023-24. So there's a bit of a wait going on here. But what do you do in the meantime? That's why we're doing this integrated care conference in the near future. And I just don't know about family practice hires through PCN. Like, these new to service contracts don't seem to be getting responded to. And why is that? Could it be all the things we talked about at the panel this morning?
Likely. Thank you so much. It was very helpful.
Thank you.
Ellen, in Comox Valley, this is Janet, our experience, and I'm not sure where the difference was, because it sounds like Rob's community was also had a very cohesive community, but the feedback we had was in the success of our Foundry application was the strength of that collective of community members that really worked together to put that application forward. So that was one of the pieces of feedback. And then in terms of the PCN funding, we've just received notice that we will have access to a 1 FTE service agreement for physician time. So it's not specifically listed as an NTP contract, new to practice contract. We have to work with the health authority to sort out how that is going to happen, but it sounds like it can be a service agreement, which is similar to what we have at our Health Connections clinic for our more marginalized population.
Thanks, Janet. Yep, go ahead.
I was going to say thank you.
Anyone else have any comments on and in their communities, what's going on? Laura?
Yeah, I just wanted to say I joined as kind of a fly on the wall because I'm super new to my role. And I'm really here with my, just listening in. I'm more of a virtual care role. But we do have a Foundry, and I'm from the Claytley-Tenay, unceded territory of the Claytley-Tenay, so more Prince George area. But we do have a Foundry, and I don't know how that was implemented and how we ended up getting a Foundry in our area. It was only a couple years ago, though, so.
Thanks, Laura. Did you want to say more about what your experience is in PCN planning in relation to your Foundry?
I really don't have any experience with PCN planning with my Foundry. Like I said, I just came into this role a couple of years ago, or a couple months ago.
Well, welcome. It's nice to have you.
Yeah, thank you.
Sarah?
Thanks. This question is for Janet, but thank you, Rob. This has been very interesting. Just kind of going back, just a quick question, hopefully. I don't want to take everyone's time around this, but around that physician for Foundry that you've just gotten approval for, just so I understand where you're at with your PCN plan. So is that over and above a PCN approval? Like, this was an additional ask? And if it was, it seems like it was. Can I ask when you asked for that? Because we've been previously told, no, we just have to stretch our PCN resources thin. So I'm happy to go back to the ministry, but would love to kind of just hear your experience on that. Thanks.
Yeah, so we did our service planning in 2018 and got approved in late 2018 with final approval in 2019. And then Foundry, the ministry edict about Foundry will be part of PCN, I think came out in 2020. I can't remember exactly, but it was certainly after we'd already allocated our resources. And at the time, our community was in a unique situation that we had 16 open practices when we were doing our service planning. So we actually didn't ask for any family physician or nurse practitioner resources except at our team-based care clinic. So the initial ask was last November of how do we embed this into our PCN, and we would need additional resources. And then we were asked to submit a change request. In the earlier session, there was the question about what was the darkest moment. I think change requests could go under that piece, but I know the ministry is working to streamline that process. But the change request went in, I think it was in June, and we just heard last week that it was approved. So it wasn't quick.
Okay, thank you so much. It sounds like our experiences are very similar. So I always appreciate kind of hearing if someone else got something, and then we can push it a little harder. So I appreciate that.
Thanks, Sarah. Thanks, Janet. Anel?
Thank you so much. I just wanted to share our experience. We have a similar experience in the sense that the planning for the Foundry in our Burns Lake area, so that is for Burns Lake and 5 surrounding First Nations communities. It happened simultaneously with our PCN planning, which was approved last November. So we made provision for a 0.5 FTE physician for them, but a lot of the overlap was more the resource allocation. We haven't really had at that point a lot of discussion on how this will be integrated into the PCN work. Whereas where we are now, as part of our PCN structure governance model, we have these local collaborative tables, if I can call it that. So the Burns Lake area has one with representation from all the First Nations communities around it. So we hope to start that conversation about integration and how we can work together on this in the near future. And then an interesting development that we had this week, we have other communities close to Burns Lake, maybe hour and a half drive, that also applied for a Foundry, and their application wasn't successful, but they're sort of interested in a regional approach towards the services of the Foundry. So I don't know where that is going to go, but we will start conversation to see if there's something that we can do better together. So it was comforting for me that there might be more applications approved 2024, 25, because there's definitely other communities in our area that is also interested in a Foundry.
I think everybody's interested in a Foundry. I feel like that's the conversation I found that really interesting when that letter came out saying Foundry will now be part of PCN planning, but so many communities, like your experience, Rob, is you tried and then didn't get it. And so then now you have to wrap it into something else. It's just, those are the edicts that come from the Ministry of Health. And then we have to figure out how to massage and maneuver within our planning to get a service that all of us really fundamentally believe equity wise, everyone should have access to. It's really interesting, but it's great that you have one. It's great for those communities that have been improved. But Rob, do you have any sense of what your next steps are around Foundry and how you go, or do you just continue planning without it and make child and youth mental health part of your service plan, excluding the idea of ever having Foundry involved?
Well, I think, why do we want a Foundry? What is it about Foundry that is so appealing? And it comes back to everything we're talking about, is that wraparound care, team-based care, the best fit for who is providing this aspect of this person's care it's all present and accounted for. And there's ability to communicate, there's ability to outreach into the community, all of those things that we're holding dear about what PCN can be, and wraparound care for youth in this case, all fits into this model of Foundry. And that's what's so appealing. So not having a Foundry takes me back to what I was saying before. What are the concepts of Foundry? Our school district representative at one of our meetings after we didn't get Foundry, she said, well, why don't we just do it ourselves? And that's where this whole concept of integration of care came from. So it's like making that shift from me working fee-for-service in my office, paid for the time I spend, suddenly being drawn into a team that are looking at the issues that this young person has, mental health or substance use. How do I shift from that what's the term I'm looking for? That need for spending your time wisely, because we are earning a living, to suddenly shifting into a team model of spending way longer than 13 minutes, for example, in a team meeting, trying to address this team-based care aspect. And that's kind of where we're in this transition, but so worth exploring, getting out of that mindset of volume-based, here's my list of patients for the day, I've got to accomplish this, into, wow, I don't have to do this all by myself. I can have all these other people helping me with so much of that care that they will do better than I can. And I don't have any problem with saying that, because a social worker is going to do a way better job of navigating our system and all those social determinants than I can. So I guess, how do we develop that? And that's really what our local conference is going to be about, is shifting the mindset first into recognizing the merits of a team-based approach. Having done that, how do we start a process of making that work? Do we just make sure our referral and consultation system is working as well as it could? Do we get feedback when we've referred somebody to child and youth mental health about what's actually going on, and where can I be involved next in the care of that young person? We don't even have that right now. So even if we can accomplish those small bits, that's a step. And then you build on those steps. Foundry would just make it way easier, just because that's the whole structure and operation of it. But if you want to invent it yourself, this is kind of the process we're going through. And it's what Chantelle would have spoken to with what she did in Kaslo in her high school. And I'm so sad that she's not here, because when she told Chris and I that story, it was just like, oh, you got to come and tell the group that story. But it is really what it is. Like, how can we offer that level of care that doesn't make us the sole responsibility for doing everything, when other people can help us so much more?
So Rob, maybe building off of that, what would you say to communities who are maybe a little bit further along in their PCN planning or their implementation phase, who haven't listed child, youth, mental health, and substance use care as a priority, or maybe it's further down on the list?
Well, I guess that's why we're here today, isn't it, Chris? Is because wherever you're at in your PCN, whether you're first wave and your PCN's already functioning, do you see, and this is what the one pager will address as well, but do you see the merit of recognizing that addressing youth mental health and what can lead into those issues for youth mental health early on in your networking for your primary care network in your community? Do you see the merit in advocating for that to be part of your network? And if you see the merit of it, which I hope you do, then how can you go about making sure that it is addressed? Because all of these concepts of a team for youth and their families in mental illness and substance use can't be addressed adequately in a short office visit. We need to do more for helping those people. So if you're already functioning in your PCN, go check it out. Is it a priority in your PCN? If it's not, advocate for it. And the one pager will kind of give you those steps as well. If you're at our stage of just developing your service plan, I agitated for forming a working group on this, and I drew together the child psychiatrists we have in our community, an adult psychiatrist, a few family doctors, and we're talking about, okay, what do we need in our community that we don't have right now that's going to help us, whether it's better communication amongst our community agencies, that's an easy one. Who is the person or people in allied health professions that we need to help us with this? We keep coming up with the need for a navigator kind of role, which in a wraparound model is critical for somebody to draw the players together to coordinate that team-based approach to a youth with often a complex history with their family as well. So it doesn't matter what stage you're at, advocacy is vital, and I hope you see the importance of it.
Thanks, Rob. And yeah, once again, we'll definitely share that one pager. Thanks for the shameless plug. Other questions, comments? Would anyone like to share their experiences in their communities? Anyone else? Would anyone like to share what they've taken away from this session? Yeah, Shelley, go ahead.
I'm curious about how you involved your school district. Did you go superintendent? Did you go counselors? What level of school district did you find, made the biggest difference?
I keep coming back to our local action team. On the local action team was the head of the counseling aspect of our school district, and she was a constant member of. In fact, it's her and her staff that actually administer our local action team now. They do all the note taking, send out the minutes, and all of that. But it was through that engagement. Now, again, if you don't have a local action team, there will be somebody in the role of kind of head counselor for the school district in your community. And it would be engaging them in helping you. And again, I'm so impressed with the education system of how they are so on these issues that we're talking about is the early recognition of mental health issues or substance use issues and the children that are at risk in the school system, and how our school district now has 2 social workers that are helping in the school system to help those families in need. And this is all like way beyond anything we're even doing in the Ministry of Health. So it's so impressive how they can help us. Like we did, 2 of us went and did an ACEs talk to the school district that was really well attended. And it was a great educational opportunity to reinforce what they already knew about the risks of childhood adversity. But it just becomes this 2-way dialogue, and that engagement just keeps building as the relationship builds. So it's really starting with who's your contact person, like the question earlier about who's your contact person for child and youth mental health, MCFD, in your community, and building building that bridge, because you're all working for the same thing.
Yeah, and just for the group's benefit, so I sit on and this is why it resonates so clearly, is I sit on a group called Student Voice for Kamloops Thompson District, so SD 73. And we have representatives from every high school within the district. And at every single meeting, these young students are crying out for more support. And sorry, I get a bit teary, but COVID has been awful for them. And they're feeling the pressures of so many kids in classes and the pressures of what it is to be an adult and the pressures to perform. And they keep saying, you know, the counselor at our school just wants to help us to get to post-secondary, and not addressing who do I talk to. So what you're suggesting can just be so powerful. So I'm very excited to have the opportunity to have just taken notes and learn something. So thank you.
Thank you. My goodness. To see how invested you are in their health. This is really so impressive. The school district, when we approached them about doing the Doc in School program, we're just like, welcome, come in. They just bent over backwards to have a family doctor and a child and youth counselor come into their school. They're so welcoming, so accommodating. It was not a hard sell whatsoever. So it's just, is there a will there to divide your already busy time into that recognition that taking your care to a school can just make such a difference to your community.
And what you've done is provide a solution for children who are asking, you know, they've got questions, who can help? And now you're providing that. So it's a wonderful template. Again, thank you.
Thanks, Shelley. Other comments around the group? Anyone like to share their experiences, their challenges? Yeah, Helen.
Thank you. I don't have anything to share, but I do have a question for the group and for you, Rob, in terms of, you had one slide at the beginning, which was really very compelling. It had sort of the 4 kind of outward symptoms, and then under, I'm not explaining it very well. It was very impressive when I saw it, and now I can't even speak to it. But there's so many factors that impact a child so that they're presenting with whatever all the challenges that they're experiencing. I'm curious what other kinds of supports that you looked at within your PCN or other advocacy work. So thinking of other ministries, social services, like all those places that could perhaps wrap around families more. I'm just curious, more the preventative side before things get to the point that we were just talking about for youth.
Well, we have a maternity working group, and Raina Sivikova is from that group. She's on this call. So much of this is educational, because what we know from research that's been done is if you start that educational aspect to a mother who's pregnant with this growing child, and you start to see that cycles of adversity are natural, because we do what we've learned. Or if you don't develop the skills moving forward, then you're going to start making the same mistakes that were made for you. So much of this is educational, and recognizing. There was a doctor from Alberta who originally came and talked to us at one of our conferences. You'll remember her name, Chris, maybe. And she just talked about her maternity clinic, where they asked this ACE questionnaire to every woman there. There's been since some worry about just blanket doing this ACE questionnaire that's very provocative and can be very triggering. But the thing was that it was a platform for having conversations with pregnant women about what adversity they might have experienced and what you can do in the next generation to try to overcome that, so that cycle isn't repeated. So there's all of these opportunities. That's where public health nurses in your community can be so valuable, as well as that educational aspect. Raina, I don't know if you want to speak to the maternity part.
Yes, thank you, Rob. I mean, it's a very, very interesting approach, and definitely close to my heart, because, you know, if we can intervene early on, starting with pregnancy and starting in those early childhood years, then this will really be a more of an upstream approach rather than a downstream approach before all those issues have happened. And definitely education, advocacy for young families with children. But also, unfortunately, I think that there should be more of a political will to invest in young families. So, and this is well beyond what we can achieve with PCN or us as physicians, but it's, you know, affordable childcare, mental health support for those moms. It's like all those pieces that, you know, if we can start things off right, we're not going to be seeing just the adverse childhood experiences passed on from one generation to the next generation to the next generation, and then trying to deal with the consequences of that when those kids are already teenagers. And it's you know, definitely a lot of work to be done, no good answers, but even just the fact that we're talking about ACEs, and I think that's extremely important.
Thank you.
Thanks, Rena.
So
Tracy,
we have 5 minutes
make...
left, and yeah, let's pass it over to Tracy, and then over to you, Rob, to respond, and then closing remarks.
I'll just speak really quickly. I did a project. I applied for a grant through BC, I think it was the BC College of Family Physicians, a social determinants of health grant, a couple of years ago, and got the funding to run a project called Mama Mood, which we made up here on the island because we don't have any public health services. So we got a group of women who had children of any age. We were going to try to do young children, but within our community. And actually it was really great. So moms came together and they had an hour of just kind of open facilitated dialogue with each other. And there was a trained counselor with them. And then that counselor was had extra funding that if she identified that some of them were specifically at risk or seemed to have areas that they needed more private, she could pull them out and give them one-on-one personal counseling for a period of time to support the issues that they had. And I have all the project and the whole thing that we did, but we ran it for 12 weeks, once a week, and we had to provide childcare, and we had to provide snacks, and we had to provide a space. And so that was where all the funding went, was to kind of actually just pay for this program and pay the counselor. And it was a really fascinating experience in terms of building community. So these women now are all friends, and they weren't necessarily friends before, from very different backgrounds, very different age kids, the older moms able to support the younger moms. It was really interesting to see how that worked. And then it was really successful. And then the challenge is now there's no more funding to kind of keep doing that project within community. And I was trying to think of how to roll it into group medical visits, but that didn't really fit the tone of the group because it wasn't medicalized. I wouldn't have to chart their conversations. I'm not interested in that. Anyway, it was a really neat project. So I think when you're looking at ACE scores and you're looking at child and youth mental health, I didn't really have a way of getting at the like 14-year-olds, but I did have a way of getting at the moms who have the little kids, who maybe if we can improve their coping and resiliency and give them support. And it was really great. It was a great project. And I'm hoping that we can maybe think about that, Rob, now as like part of PCN. How do we make that something that we can find funding for? So yeah, I think looking at the whole life cycle is the key for sure.
That's inspiring, Tracy. And it just keeps coming back to the power in the community and how, you know, there's this term called self-healing communities. And if they have that opportunity for that connection to develop, there's so much power in how they can help each other, even without us having to be a part of it. If you just create a crucible for that connection to happen.
I didn't attend a single session. Like I wasn't involved as if I just coordinated and got the funding and did it because they needed a family doctor, but I literally had no interactions with them as a group. They all knew that I had done it, but there was no, they did it themselves, and it was very powerful. So when anyway, I think you're right that the community has resiliency if we just have to be the ones to plant it.
Well, do you want me to sum up, Chris?
Yeah, that would be great.
Okay.
Thanks, Tracy, for sharing that. And yeah, go ahead, Rob.
Wow, what a fantastic discussion. I really want to thank everyone for being here and all the contributions. It just becomes such a rich dialogue, and I think we all learn so much from that sharing of information. So onwards, I'm so pleased that you're interested in the advocacy for this in PCN at whatever stage you're at. If you're interested in learning more, Chris is our project manager for a short time longer for the Community of Practice Child and Youth Mental Health Substance Use Provincial Initiative. And love to have you part of that 270 member group around the province if you are interested. And thank you for being here. And I really appreciate all of your input. Cool.
Thanks, Rob. And thank you so much, everyone, for joining today. And please feel free to email me if you'd like to get in touch and join the community of practice or just want more information. If you have any further questions for Rob, I can put you in touch. So no problems there. And I hope you all enjoy the rest of the sessions today.
Tracy, did you have a comment?
No, I was just going to say thank you.
Oh, okay.
Yeah,
okay.
Thank you.
Okay.
Thanks,
Bye
everyone.
for now.
Bye.
Bye-bye.